Hi, I'm very happy to give this presentation today. I'm just so sorry that we need to do this remotely rather than in person. I'm going to speak about an incredibly important topic today. I'm going to speak about survivorship after acute respiratory failure. In particular, I want to focus on patient-centered outcomes and how this impacts the research and the clinical work that we do in these areas. Much of what I'm going to speak about today is available at this website, improvelto.com, where LTO stands for Long-Term Outcomes. I was very fortunate to be principal investigator on a large 7-year US NIH-funded grant that aims to enhance infrastructure and provide free resources for researchers in the field. And this 7-year grant was focused on how to improve long-term outcomes research for survivors of acute respiratory failure and ARDS. This research grant, by way of background, had 3 aims. The first aim was related to outcome measurements. How do we decide and use the proper instruments for evaluating ICU survivors? The second is how to retain these survivors in our long-term outcomes research. It's very challenging to have that retention of participants and reduce loss to follow-up as we follow them beyond hospital discharge. And the third aim is related to statistical methods, another complex area of what are the best statistical approaches when we can't measure the functional outcomes because some of our survivors have died. And this is particularly important in the setting, for example, of randomized trials where there may be differences in mortality rates between the 2 treatment groups. How do you evaluate the effect of that treatment on patients' functional outcomes when there's differences in mortality between the 2 groups? But what I'm going to spend most of this hour speaking about is the first of these aims, understanding, measuring patient-important outcomes after hospital discharge. So today's presentation will have a number of steps. It will start with a scoping review, and then we'll jump in to speaking about core outcomes and core outcome measurement sets. In particular, a great deal of today's presentation will focus on understanding what are patient-important outcomes, and then talk about some of the measurement issues around evaluating these with measurement instruments, and then talk about an international modified Delphi consensus process that we undertook to get consensus around which outcomes and which outcome measurement instruments should be used in all studies of ICU survivorships. That's a small minimum set was the purpose of that core outcome Delphi project. So now the scoping review. So this scoping review looked at all of the ICU survivorship studies that looked at patient outcomes beyond hospital discharge. At the time that we did this review, there were 425 publications. And as you can see in this figure, there's an increasing number of publications each year. Importantly, across these 425 studies, there was great variability in the types of outcomes reported. 65% of these papers reported a quality of life measure. But when it comes to an in-person assessments of patients' physical activities, that was evaluated in only 6% of all of the papers. What this reflects is a lack of standardization across ICU survivorship studies. And that creates a limitation. It limits our ability to have comprehensive assessments and to have consistency and comparability across the field of ICU survivorship research. And these are important things to aim for if we want to move the field forward. So by another example, across these 425 papers, 250 different measurement instruments were used. How can we ever synthesize a body of research if we're all measuring with very different instruments. The downsides of this historical approach to ICU survivorship research is that important patient outcomes may not be assessed. They may simply be overlooked. It's also very difficult to compare results and difficult to perform meta-analyses. There also is a chance of selective outcome reporting leading to potential bias, particularly in randomized trials. So what I want to move to is some of the solutions for the problems talked about in that scoping review. I'm going to talk about core outcome sets and core outcome measurement sets. So first, a couple of definitions. What's a core outcome? It's a concept, health-related condition, or aspect of health that must always be measured within a specific field of research. So this addresses what outcomes should we all measure in ICU survivorship research. A core outcome measure is an agreed upon measurement instrument for that outcome. So this addresses how should we measure the core outcomes. And then a core outcome set is the minimum collection of outcomes that we believe should be reported in all studies within a specific field, the minimum set. And a core outcome measurement set is the minimum collection of measurement instruments that should be used and reported in all studies within a field. Importantly, these core sets do not prevent investigators from collecting data on other outcomes or using additional measurement instruments. This is supposed to be a small and feasible minimum set of measurements. This program of research also does not require everyone to do outcome assessments after hospital discharge. This core set project is created for those who already are making the decision to evaluate patient follow-up after discharge and trying to get consistency among those researchers and studies doing post-hospital discharge research. This doesn't mandate post-discharge outcome assessment. It just gets those people in the field to have greater consistency. So the biggest part of today's presentation that's relevant to everybody, both researchers and clinicians, is what are patient-important outcomes? I think many people in the field have said, oh, we don't understand what are patient-important outcomes. Let me tell you that we do. Fortunate to, for example, this 7-year program of research. So how do we understand what are patient-important outcomes? Let me take you through a pathway. I'm going to talk about all of the bullet points on this slide, but I'm first going to start with a national qualitative research study that we conducted in the United States. So this qualitative research was done to help us better understand the ICU survivorship experience for ARDS and acute respiratory failure patients. We did semi-structured interviews of 48 survivors recruited from 35 hospitals across the United States. They were interviewed at a median of 9 months after hospital discharge. We did semi-structured telephone interviews using open-ended questions initially, and then giving prompts so that we could go through each potential aspect of the survivorship experience prompted by the PROMISE framework. And this NIH PROMISE framework, I'll talk about a little bit later in today's presentation. So what are the key findings from this qualitative research? We found that physical impairments, such as problems with mobility, pulmonary symptoms, and decreased stamina, were commonly reported in this qualitative research. Survivors also commonly talked about mental health problems such as depression, anxiety, and concern about getting sick again. Social health was also discussed. This means issues like return to work and participating in patients' usual activities. So that was a single qualitative research study with a sample from across the United States. We then went on and did a systematic review of all qualitative studies published from around the world. So at the time of this systematic review, we found 21 qualitative studies of the ICU survivorship experience. And the key findings across the systematic review of qualitative studies were that physical function, mental health, and social health were considered important relatively consistently across these qualitative studies. And some qualitative studies, interestingly, reported that patients had positive impacts of their critical illness. They had increased gratitude or a new positive outlook on life after their critical illness experience. So that was an important new finding in this systematic review of qualitative studies. So if we try to synthesize the national qualitative study in the US and this systematic review, I think that we can find that there are impairments across many different outcome domains, that some survivors have a positive impact on their attitudes and outlooks after their critical illness, and that social health impact is important despite it not being reported in some empirical or quantitative studies. So what about patient outcome measures that are commonly being used? How does that reflect the ICU survivorship experience as reported by patients in qualitative research? So this is a novel study that we completed. And what we wanted to do was understand how those outcome measures compare to the patient-reported experience of survivorship. So we looked at those semi-structured interviews and the results from that national qualitative study in the 48 survivors of acute respiratory failure. And fortunately, those 48 survivors also had undergone a battery of patient-reported outcome measures and cognitive tests. So in this novel study, we compared from the physical domain patients' reports of having mobility impairment, and we compared those qualitative open-ended reports to patients' mobility score on their EQ-5D measurement instrument and the physical component summary from their patient-reported SF-36. In terms of mental health, we looked at patients' qualitative interviews where they talked about anxiety, depression, and post-traumatic stress disorder symptoms. And we compared patients with and without those symptoms by their scores on the Hospital Anxiety and Depression Survey for anxiety and depression symptoms and the Impact of Event Scale Revised for PTSD symptoms. And then finally, we looked at patients who qualitatively reported having memory impairment, and we compared this against objective cognitive tests for patients' memories, as shown here. So that was the study design. What did we find? So in terms of patient-reported mobility impairments, we found that the SF-36 and the EQ-5D scores were markedly worse. The scores were worse in those patients that qualitatively reported having mobility impairments. So those two measurement instruments appeared to reflect the patient experience of mobility impairment. Also, in terms of psychological symptoms, the HADS and the IESR measurement instruments also were markedly worse in patients that endorsed having these kind of symptoms. So again, those two measurement instruments seem to reflect the patient-reported experience of psychological symptoms. And then finally, in opposition to those two prior results, we found that the cognitive test scores were not associated with patients endorsing memory impairment. So the patient report of memory impairment was not associated with the findings, the objective findings from cognitive testing of memory. So what we found in summary is that commonly used outcome measurement instruments do reflect survivorship experience from semi-structured interviews in terms of mobility and physical functioning, anxiety, depression, and PTSD symptoms. However, patient-reported memory impairment is not reflective of their cognitive test scores. So that's really important to know that cognitive testing needs to be done rather than solely reporting on patient-reported outcomes for their cognition. So what about clinician perspectives? What do clinicians think should be measured when looking at patient-reported outcomes and survivorship research? I'm going to talk to you about a pilot Delphi consensus that we did. This consensus project was done both in the United States and then completely separately in Australia. So in the United States, we had 100 clinicians respond to an online survey, and then 44 of them attended an in-person meeting in which we conducted a modified Delphi consensus process to figure out what outcomes clinicians thought were important. And then this same project was separately done in Australia with 78 clinicians, primarily physical therapists, reporting through a survey, and then 85 attending an in-person meeting for a modified Delphi consensus process. So what we had people vote on were 19 different domains, 19 different possible outcomes that may be important. How did we figure out these 19 different domains? We looked at the PROMIS, the United States PROMIS framework for patient-reported outcomes, as I'll talk about in a minute. We also looked at the domains within the Society of Critical Care Medicine post-intensive care syndrome framework. And then finally, we considered the World Health Organization's International Classification of Functioning, Disability, and Health. And at every step, we also asked for patient and clinician and researcher input. So we went through this process to come up with 19 potential domains for these studies. So the PROMIS framework that I've talked about, this is a fantastic approach created through the National Institutes of Health to help us understand patient outcomes after any kind of events. It helps us understand patient-reported outcomes. It says that patient-reported, self-reported health can include physical, mental, or social health. And then in this figure, it talks about certain outcomes or domains within each of physical, mental, and social health. So this was used to help us generate 19 domains for evaluation in this international Delphi. And then this, of course, is the Society of Critical Care Medicine's Post-Intensive Care Syndrome, or PICS, framework. And this emphasized to us that we should be exploring mental health, cognitive impairment, and physical impairments when we do these kind of domains and evaluate patient outcomes in these studies. And then finally, the World Health Organization's ICF, or International Classification of Functioning, tells us that when we're thinking of patients' function, we need to understand structure and function impairment, which may be done with imaging, for example, or muscle strength testing. We also need to understand activity limitations that may have patients doing actual performance-based tests. And then we should think about participation restriction or patient-reported participation in real-world settings. So that also provided us some lenses to think about these domains. So again, this is a list of the 19 domains. On the left side are the rankings in the United States modified Delphi consensus. On the right side is the Australian ranking. And importantly, more than 70%, both in the international US-based project and in the Australian project, more than 70% agreed that the following outcomes should always be measured when evaluating ICU survivorship. That should include survival, physical function, cognition, and health-related quality of life. Those were core outcomes that agreed across the United States and the Australian work. So now I'm going to talk about actually asking patients, family members, and researchers to weigh in also on these same 19 domains. So here, this was a survey with 280 participants. There were 78 ARDS or acute respiratory failure survivors from across the United States that were surveyed via phone, and we had 80 family members, including 55 pairs of family member and survivor, again from across the United States, where about 50% of the family members were a spouse and about 20% were an adult child. And then we had 121 researchers from around the world who completed the same type of survey online. 60% were from Europe and about 25% from North America. So we did this large survey to evaluate these same 19 outcomes, the same outcomes that were done in that Australian and United States Delphi. And in this work, we asked the patients and the family members and researchers to rate each of the 19 outcomes regarding the level of support for requiring it to be measured within a minimum set of domains for ICU survivorship research. So what did this survey tell us? Interestingly, we found that patient and family members had similar findings and similar survey results. And patient and family members agreed or strongly agreed regarding the importance of 18 of the 19 outcomes. So we have hit outcome measures that really seemed important to patients and survivors. And that's important because those outcome measures were evaluated in the subsequent international Delphi consensus that I'll talk about upcoming. We found that researchers rated all of the 19 outcomes except for survival less strongly than the patients and families, probably because the researchers were tuned in to the burden of responses that are needed if we're going to evaluate all 18 or 19. But interestingly, when we combine the perspectives of patients, family members, and researchers, they all provided strong support saying that the following outcomes should always be included in survivorship research: physical function, cognition, mental health, and return to work or prior activities. So all of these slides that I'm presenting is to help you understand that there's a large body of research around patient-important outcomes for ICU survivorship. It also tells us that family members are very important to get their perspectives because they don't always agree with researchers. So if we want to synthesize that national qualitative research, the systematic review of all qualitative, the Australian and the United States pilot Delphi consensus projects, and then this large 279-person survey, if we were to synthesize those all together, what seems to be the conclusion for patient-important outcomes? Well, across those studies, important outcomes to consider include survival, physical function, cognition, mental health, social health, including return to work or normal activities, and quality of life. So over a few years, and looking at this from many different perspectives, we have some great consensus. So now that we know what are important outcomes, how might we measure them? What do we know about the measurement properties of instruments for these types of outcomes? So here we did another systematic review and found that in the field of critical care survivorship research, there are only 20 studies evaluating 21 different measurement instruments that have been done. So there's a relatively small body of research regarding psychometric properties of instruments for ICU survivorship research. And unfortunately, many of these studies only had poor or fair ratings when we looked at their methodologic quality and reporting. So there really is a lot of room for improvement and growth here. And with the NIH funding, we went on and did a whole series of additional psychometric analyses to help us understand use of these kind of instruments in ICU survivor populations. So with the hospital anxiety and depression scale, we looked at its internal consistency in ICU survivors. Also for the HADS and a PTSD measure, the ISR, we looked at distribution-based methods for minimum important differences. We looked at how those mental health specific instruments compared to the SF-36 mental health domain. And we actually found pretty good associations there. We then went on and looked specifically at the ISR PTSD instrument to see how it compared to a reference rater diagnosis of PTSD. And that instrument performed very well. We then looked at a much shorter 6-item version of the ISR and showed that that performed very well as well. So these instruments seem to work well in ICU survivors. We then compared these kind of instruments along with the qualitative findings, as I already showed, showing that these instruments do reflect findings in ICU survivors. And we are continuing to do work in the area of fatigue. So those are kind of patient-reported outcome measures. What about performance-based tests? We conducted 2 separate papers where we showed that the 6-minute walk test and the 4-meter gait speed test worked very well in ICU survivor populations that we can assess in person. We also looked at how these performance-based measures of physical function compared to patient-reported outcomes. And there are some very important findings in that paper in thorax that I cite here. And then we also looked at DEXA scanning. We looked at this gold standard for body composition to see how it compared to upper arm anthropometrics and how that muscle mass compared to patient performance with things like 6-minute walk test. So there's a whole large body of research. I won't go through the findings of each of these studies, but a lot of psychometric research was conducted. So all of that leads into this international modified Delphi consensus process. So what is this Delphi process? So this is a consensus method for experts to address questions where empirical data are unavailable or inadequate. We're never going to have an empirical answer to what are core outcomes and what are core outcome measures. We need to get experts to decide and reach consensus. And this Delphi process includes recruiting a panel of informed experts, maintaining anonymity of those panel members so they don't influence each other, and providing a summary of the voting results after each round of voting and feeding those anonymous results back to each panel member to see if they want to change or modify their results. And then, of course, we need an a priori criteria for how we define consensus. So with our NIH funding, over about a 1-year process, we conducted a 5-round international Delphi consensus process to tell us what should be the core outcome set and the associated measurement instruments as the minimum set for all of ICU survivorship research. So we put together an international Delphi panel with input from a number of different stakeholders for who should be part of this. And importantly, we partnered with the INFACT organization, the International Forum for Acute Care Trialists, to ensure that we had representation from major critical care trial groups from around the world. So we put together a panel of 77 panel members. About half of them were clinical researchers representing more than 16 countries and 6 continents. About a quarter of the panel members were clinicians or official representatives of clinical professional associations, and about a quarter were patients and family members. And these clinicians and patient and family members were recruited from the 4 countries that had the largest wealth of research in critical care survivorship. That's Australia, Canada, the United States, and the UK. So we put together that multidisciplinary international Delphi panel. And here are examples of official clinical research trial groups that were represented in this Delphi consensus panel from all around the world that you can see here. We also selected other internationally recognized clinical researchers in the field, as well as corresponding authors from published ICU survivorship research. We had representation from 4 federal funding bodies in the United States, and we had patient and caregiver representatives from 4 different countries, as shown here. We also had clinicians and the official representatives from nursing, medicine, and PT bodies in Australia, Canada, and the United Kingdom, and then an expanded group of professional bodies on an international basis or in the United States, including the Society of Critical Care Medicine, the American Thoracic Society, the American College of Chest Physicians. So that was our panel, and we brought them together for 2 Delphi rounds to find out what were the core outcomes that should be measured as a minimum in all ICU survivorship research. And we gave this panel most of the data and the studies that I've already outlined to you. We then got them together, we gave them those 9 outcome measures that I talked about, and the panel suggested 8 others that they wanted to consider. And we did 2 rounds of voting with 97 and 99% response rate. And the panel members were instructed to vote without consideration of the availability, feasibility of measurement instruments. We just wanted to say, are these outcomes important? So we provided 19, they suggested 8 more, and we came up with core outcomes, as I'll show on the next slide. We then also did 3 rounds of Delphi process for measurement instruments for these core outcomes. And we gave people that scoping review. We gave the Delphi panel a 1-page summary of measurement properties of every measurement instrument being considered. So they didn't need to be an expert on the measurement instrument because we gave them relevant information like the time it took to complete, the cost, the psychometric properties. And then we explained also what the psychometric properties meant, particularly for people that weren't researchers. We provided 38 possible measurement instruments, and we said to the panel, can you suggest others? They suggested 37 additional measures, and we explicitly asked them to consider the feasibility, the ease of use, and the psychometric properties of these instruments when making their decisions. And we had between 91 and 97% response across the 3 additional Delphi rounds. So what did this long 1-year process reveal? So these are the 8 core outcomes. We reached consensus that this is the minimum set of outcome measures that are recommended to be used in all ICU survivorship research. We should evaluate survival, health-related quality of life, mental health, pain, pulmonary function, muscle or nerve function, physical function, and cognition. That's 8 core outcomes in the core outcomes set. Then the second 3 rounds of Delphi said what measurement instruments should be used. So for the top half of this figure, there was consensus. For survival, we didn't ask. We recommended that the date and the location of death be recorded. For health-related quality of life, there were 2 instruments that reached consensus, the EQ5D and or the SF36. For mental health, it was the Hospital Anxiety and Depression Scale and the Impact of Event Scale Revised for PTSD. And then for pain, consensus was reached not to use a new pain instrument, but to simply use the pain item within the EQ5D as part of the minimum core outcome set. Now, the bottom half of this figure is very important. These are outcomes that often would be evaluated through in-person testing. And I read all of the Delphi panel member responses, and there was a big tension. People felt that in-person performance-based testing were likely the best way to evaluate these outcomes on the bottom half of the figure, but they didn't feel that it was feasible to mandate that performance-based tests always be used. For example, in a large national study, it may not be feasible to do in-person assessment with the 6-minute walk distance. So what we found is that for 3 of these measures, cognition, physical function, and muscle or nerve function, consensus was not reached. However, the highest level of support within cognition, for example, was for using the MoCA instrument. And the MoCA instrument can be done via phone. For physical function, the highest level of interest was with the 6-minute walk test, but it didn't reach consensus. It didn't reach the threshold for consensus, but that would be what I would recommend if you have the ability to do a performance-based measure. There was no patient-reported outcome measure that reached consensus. And for muscle or nerve function, once again, no patient-reported outcome, but there was a high level of interest for manual muscle strength testing and or hand grip strength. And then interestingly, consensus was reached in the bottom right corner around pulmonary function. There was consensus that there was no existing measure that was appropriate to be used as a minimum or mandatory measurement instrument. People recognized that pulmonary function testing like spirometry would not be feasible to mandate in all studies. So here are different configurations of the core outcome measurement set. The minimum has 3 instruments, 42 questions, about 12 minutes to complete by phone, and costs about $1.50 in licensing instruments. People then can add on the optional MoCA phone-based instrument to measure cognition, despite it not reaching consensus. This adds a few more questions, a little bit more time. People that want to do a deeper dive in quality of life can add on the SF-36, which does add more time, a little bit more cost, and more questions. And then people that want to do everything can do the whole battery. That's 91 questions, about 26 minutes in ICU survivors, with a licensing cost of about $3 per assessment. Importantly, all of these instruments in the core outcome measurement set are available in at least 15 languages, including Korean. So this core outcome measurement set can be administered in Korean to help so many people doing ICU survivorship here in Korea. What about endorsements? What do other people think? I'm going to present 4 panel member recommendations. So the first comes from an NIH body that was a working group for clinical research in adult pulmonary and critical care research. They recommended that studies do evaluate patient-important outcomes beyond hospital discharge in both observational and randomized trials. And they specifically recommended using this Improve LTO core outcome measurement set for that purpose. They said that the future does need to focus on understanding and evaluating baseline status and trajectories, and also evaluating outcomes in family members and healthcare providers. The Society of Critical Care Medicine had an international consensus conference on long-term impairments after critical illness. They were focused on what should be done in screening for clinical purposes, not for research. And here it was an international consensus process with clinicians, researchers, and ICU survivors. And they came up with consensus-based recommendations saying that the HADS, Hospital Anxiety and Depression Instrument, the ISR instrument for PTSD, the MoCA, and either the 6-minute walk distance or the EQ-5D should be used in all clinical assessments of ICU survivors. And now, in the face of COVID, the European Respiratory Society and the American Thoracic Society coordinated an international task force to give interim guidance on rehabilitation in hospital and post-hospital phase. And there were many items that were recommended for both inpatient and outpatient rehab, for screening, and for outcome assessments. And these recommendations included that these survivors get assessed for physical and mental health status after hospital discharge. So that's a recommendation for COVID survivors. And they specifically recommended using the core outcome measurement set, as I've already described. And then finally, the fourth recommendation comes from an international body that looks at sedation-related research. So an in-person meeting was convened with international representatives, including patient and family members, and then a 3-round online Delphi consensus process was done to try to understand what should be done to advance sedation research in the ICU. And this covers recommendations for the design, enrollment, conduct, and outcomes and measures for sedation research in the ICU. And as part of the international Delphi, the core outcome measurement set reached consensus that it should be used to assess long-term outcomes in sedation-related clinical trials. That reached consensus by round 2 of 3, with 77% of panel members voting that it was critical to use this core outcome measurement set that I described. So there are many studies that are ongoing and published that use this core outcome measurement set. If you go to this webpage, you'll see a list of many studies. This is just a small sample here. But this work isn't done. There's many things that we need to do to continue to improve the ICU survivorship research agenda. We need to get input from survivors and researchers regarding the core outcome set. We need to look at smarter ways like computer adaptive testing to see if we can reduce redundancy in questions. We need to specifically evaluate the MOCA instrument in ARDS survivors. It didn't reach consensus because there's very little data evaluating its measurement properties. We need to also look at manual muscle strength testing and grip strength to understand measurement properties and feasibility in ICU survivors. We need to evaluate patient-reported outcome measures for physical functioning because consensus was not reached there. We need to evaluate the pain item from the EQ5D, which was recommended. So there's many, many things that need to happen, including, last but not least, a feasible measure for pulmonary symptoms, particularly important after the COVID pandemic as well. So interestingly, we have gone on to get feedback from users of the core outcome measurement set. We have a very simple survey of no more than 5 questions that can be asked of research participants and also asked of research staff to get their feedback on the core outcome measurement set. So this is available, and we do encourage that if you use the core outcome measurement set to include both of these surveys of patients and of research staff. And if you're interested in a synthesis of all of the research that I've presented, I strongly suggest that you look at this free full text article that in a single paper summarizes all of these data. And if you are interested in doing a study of ICU survivorship after hospital discharge, I strongly recommend that you look at our website, and you can contact us via email, and you can follow us on Twitter. I also want to spend a minute and say, what was this Delphi process like? We specifically asked the panel members to give us feedback and to talk about dissemination of the results. This is the first of 2 papers in the Journal of Clinical Epidemiology. In this paper, we did an online survey 3 months after the Delphi to ask the participants, including the patients and family members, for feedback on participation in the Delphi. We had a 92% response rate from 14 countries and 6 continents. And the panelists told us the following. They agreed or strongly agreed that they considered the written comments of other panelists from the prior round when doing their next round of voting. So people's input really did matter. And they also looked at prior voting results from the prior round before voting on the new round. 83% of people agreed or strongly agreed. 56% of the panelists reviewed at least 3/4 of all of those information cards that summarize the measurement properties. So that was very important. And the top 3 attributes of measurement properties are shown on this slide. So for example, the mode of administration was thought to be really important, along with the 2 other attributes on this slide. Interestingly, the Delphi panel members also agreed or strongly agreed that participation in this process was important. 96% of people agreed or strongly agreed. They thought the time required was appropriate. They were not bothered by our multiple attempts to contact them to optimize our response rate. And 89% would be willing to participate again. 97% of the clinical researchers agreed to using the core outcome set in their research. And then when we compared the family members and the survivors to the other stakeholders, we found that a similar percentage of them agreed that the time required to participate was important. So this wasn't too burdensome to the ICU survivors and family members. And 73% of them said that they would participate again. That was lower than the other stakeholders, but still a very favorable finding. And here is a second paper in the Journal of Clinical Epidemiology, where we looked at ways to disseminate these findings. And we described what our panel members suggested versus what we actually did and the impact of dissemination attempts on registration at our website. So we had 71% of survey respondents offer ideas for dissemination. And the top 7 dissemination categories, along with the percentage of respondents, are shown here, with the top recommendation to be doing exactly what I'm doing now, to present the findings to professional associations to help spread the word, as well as online and social media. But the top was this kind of presentation, was the most recommended for disseminating the results. We found, based on our actual experience, that all 7 of these types of dissemination were feasible. We'd actually conducted all of these ourselves. We also found that, interestingly, social media like Twitter was highly effective at increasing the number of registrants to our website that disseminated the results compared to live presentations. So we had the similar number of new registrants to the ImproveLTO.com website with Twitter or with live presentations. The panel members did also suggest some dissemination methods that aren't in guidelines for core sets, so some important information to move forward. So I want to wind up with just a little bit more information about all of the free resources available at ImproveLTO.com. We can see here, if you're interested in measuring ICU survivorship outcomes or rehab-related outcomes in the ICU, you can go to the website, click on the instrument tab, and see that there are measurement instruments for cognition, mental health, physical functioning, and then there are surveys, there are tests. There is so much information here. And for every one of those instruments, there's a standardized page that talks about the measurement properties and the practical aspects of using that instrument, including videos or websites for more information. There also are resources for how to create core outcome sets. So if you want to do this similar kind of work for a different question, we've put many resources for core outcome sets and Delphi projects on our website. What if you're conducting a study or you're following ICU survivors beyond hospital discharge? On this website, we also have a menu of cohort retention tools. You can freely download any of these tools and adapt them translate them for your use in your own studies. And importantly, we have a searchable database of retention strategies for longitudinal studies of ICU survivors. We've done a systematic review of this process, and we put all of these strategies and suggestions into a searchable database with more than 600 cohort retention strategies in this database. So you can use evidence-based approaches to improve retention of participants in longitudinal follow-up studies. Plus, here are more than 30 tools available that you can download, adapt, and use to improve and optimize retention of participants in longitudinal follow-up studies. One of our most popular instruments here is a checklist of many different methods to try to find any participants that we've no longer been able to find using traditional methods. We call this the hard to find participant checklist. So that's a great way to make sure that we're using all the different resources to try to help find a participant to retain them into a study. And then the third part of the website is around statistical methods. What approaches should we use when we can't evaluate functional outcomes because of patient death? So here's a paper that we published in the British Medical Journal that nicely reviews the 3 major methods for statistical approaches in this field. So we've written this at a clinician researcher level. I hope that this would be very helpful. We also created a standalone statistical application. You can go to our website and you can put data into this, and it will take you through and calculate for you all of these different statistical approaches. So if you don't have the ability to do some of the more complex statistical approaches, this app on the website can help you. So once again, I want to wrap up and say that I would very much like you to contact us. Go to our website, register, email us if you want to use any of these resources or if you have questions. It's so important that we understand the ICU survivorship experience, and it's so important that we design and conduct ICU follow-up studies in the most rigorous way to improve our patient outcomes and reduce the burden of post-intensive care syndrome on our survivors. So with that, I just thank you so much for this opportunity to speak to all of you. I am so sad that we have to do this through Zoom, but I hope that over the coming months that the pandemic will get better. And before we know it, next year in 2022, we can join together, have conferences together again, and I can see all of you and speak about ICU survivorship. So thank you so much for your attention. I very much look forward to any contact, any questions through email for us to help you with ensuring that patient-important outcomes are considered in all of our ICU survivorship research. Thank you so much.